Okie dokie. So today we are going to move into our skills book. We're going to be in chapter 18. Some of this is covered in the big Bible book. Just like any other class that you have, if you need more clarification, then you can always go to the big Bible book to get a little more information if you need it. I'm going to turn off my video so you don't have to see me taking my glasses off every 5 seconds so that I can cry, wipe my eyes because of my allergies. Right. Make sure everybody's all signed in and we will get started. Pardon me, I had to move my stuff. All right, so today, as opposed to yesterday we talked about nutrition and all the things that make your body go round and round. Now we're going to talk about exercise, mobility, and immobilization devices. Some of these slides, and I posted this in your Canvas, this PowerPoint, but some of these slides really don't make a whole lot of sense if you've never done some of this before. Like the slides that show you how to crutch walk and things like that, it doesn't really make a whole lot of sense on paper. So I did post a video for you in Canvas. It is my favorite nurse friend. She's showing you guys how to ambulate with crutches, a cane, and a walker. So we are learning how to crutch walk tomorrow, and we are using the gait belt tomorrow. So I do have a couple of videos embedded in this PowerPoint, but there's, like I said, there's also a couple of videos that I put in your Canvas just to kind of help you see what we're doing, right? So like I said, we're in chapter 18 if you're following along. All right, so today we're going to talk about the importance of mobility and promoting movement with our patients. We'll review the steps associated with ambulating your patients with canes, walkers, crutches, and gait belts. We'll discuss range of motion exercises. We'll talk about the use of anti-embolic stockings and sequential compression devices, or SCDs. And we'll talk about care of patient with a immobilization device. All right. There's also, I believe tomorrow one of our checkoffs is, let me look at your calendar so I don't start to lie into you. Providing an enteral feed. If you guys have access to the, for your book with that little code, you go in there, there's a video under chapter 13 for providing an enteral feeding. So if you want to look at that before tomorrow, I may play it for you guys when you get in tomorrow, just according on how I feel. I'm kidding, of course, I'll play it for you. All right, so let's get started. All righty, so what's the point of exercising?
Burn calories.
Burn calories.
Maintain
right?
fitness.
Absolutely, maintain your fitness. Make sure that your body stays in good health and maybe to improve your health. I mean, and if you've ever had a, what do you call them? Oh gosh, what are they called? They help you at the gym. Personal trainer. If you've ever had one of those, then the point of exercise is to make you die. That's my personal opinion. Sometimes they get a little out of control with what they're asking you to do over and over again, right? But so when we're healthy, of course, we like to exercise, or we don't. But when we're sick and when we're not doing too hot, it's still a good idea to keep moving around, right? Because you don't want to become immobile, completely immobile, and you still want to do for yourselves. So according to what your patient has, you still want to make sure you're ambulating them early on and often. So your patient, if you guys have ever had surgeries before, you know, your nurses will try to get you up out of bed within the first 24 hours, depending on what you've had done. My C-section, my hysterectomy, I was up out of the bed that evening. My nurses were not playing around with me. They said, you get up out of this bed. Also, I refused to wear those stockings. So I've said, well, I'm not going to spend 25 minutes with you putting these socks on me. So I'm gonna get up out the bed. And that's what I did. So, but everybody, you know, it's a little different from everybody depending on your pain levels and what have you. So whatever's your patient's going through, we want to make sure that we're getting them up out of bed. And if they can't get out of bed, at least moving around in the bed, sitting up on the side of the bed if they can, and moving them around, moving those joints around, all right? It's a good idea if you have a patient, especially in a facility, excuse me, if they're, let's just say they're bedridden, right? Or even if they're not bedridden, you can incorporate your exercise into their ADLs, those activities of daily living. So, I mean, it doesn't have to be something as strenuous as doing squats and lunges and sprinting around the room, around the corner, or anything like that. It could be something as simple as, you know, all right, while I'm brushing your hair, just lift your arm up for me. You know, while you're brushing your teeth, hold your other arm up, move it around, do arm circles. You know, it doesn't have to be anything strenuous, but it just has to be something to get them to move around, all right? For you as nurse, please make sure that you are utilizing those proper body mechanic techniques to make sure that you don't get injured and that your patient doesn't get injured as well, okay? So, and you'll see there's one of the videos that I have in here where the nurse or whatever the lady is doing great body mechanic technique. Save your backs, make sure you don't injure yourself or your patient while you're trying to offer exercise or ambulate them, okay? Evidence-based practice. Now, these are those practices that we've come across because someone has researched and found out this is the absolute best way to do such and such. So we don't want our friend Peter to fall here like he is with his walker. We don't want that to happen. So in order to prevent that from happening, we want to make sure that we teach him the proper ways to use his walker, you know, what kind of terrain he should be walking in, you know, how to be careful when he's using those assistive devices. We want to make sure that that they are properly fitted for him. Okay. So we all know that these disabilities and mobility problems, they start to increase with age. You know, me walking up the stairs now is very loud because all you hear is my knees crack and pop. Each stair is a crack and a pop. And that's just happened over time, getting old, and from running and playing sports and stuff when I was younger. Perhaps my knees need some tending to. But as we get older, you start to have those mobility problems, right? So we offer those assistive devices such as canes, crutches, or walkers that will help to improve your patient's balance, give them support when they need it, and most importantly, it helps them to remain active and independent, right? Because, you know, I don't know about you, but I'm pretty stubborn and independent when it comes to most things. I don't want help. I know that sounds terrible, but no, I could do it myself. I sound like a 2-year-old half the time, right? I could do it myself. I don't want your help. But when I get older, there may come a time when I may need some sort of assistive device. And I will take it because I want to remain as independent as I can without having to rely on, you know, I got to stay in the bed until somebody comes over to help me. If I could just get up with a walker or a cane, I'd rather do that. Okay. So remember, whenever you have a patient who is going to be using a walker or crutches or canes or anything like that, make sure you have PT involved, physical therapy, because they will help to make sure that it's properly fitted for the patient. And by that, I mean, we want to make sure that the walker is not too tall for your patient. We want to make sure that your canes and crutches fit properly for the patient, so that we can prevent falls from happening. Okay. If your patient, you know, goes to the store and, you know, let's see, several years back when my child was in daycare, they had the old lady day. So all the kids dressed up, well, not old lady, but old people day, where all of the kids dressed up as old people. So he just went to Walgreens and bought a cane because, you know, what old person doesn't have a cane, right? So if I were needing a cane in real life, I would make sure if I'm buying one of those devices from the store that it's fitting properly, right? So when you go to the doctor's office, you want to make sure that it's the right height and it's the right type of cane for you or for your patient. Okay. All right. If you are going to ambulate your patient, let's just say they're in the hospital, they may have IVs, they may have catheters. They may have an EKG going, you never know. But make sure when you get ready to ambulate your patient that any of that equipment that they have on them does not get dislodged, all right? Because we don't want to cause any injuries, right? If you're walking around and your patient accidentally trips over their catheter, they could accidentally pull it out, okay? That's a fall, and we've caused some trauma to the urethra. So we don't want to do that. So make sure that you've got everything secured whenever you're going to ambulate your patient. Getting them up out of bed, make sure you know where IV lines are, where catheters are, and any other lines that they may have, any drainage devices that they may have, wound vacuums, any of those things. You want to make sure where the lines are so that you don't accidentally dislodge them or that the patient doesn't fall over them, right? Be familiar with what your patient is using. So if they use a walker, have a working knowledge of how a walker works, right? So that you can see if your patient is using it properly or if they need a little bit more assistance on teaching them how to. Like I said, if a physical therapist is available, make sure that they have watched the patient and taught the patient appropriately how to use their devices, all right? Talk to your patients. See how they feel about walking. You know, are they ready? Have they fallen? How long has it been since they've been up? How far are they walking when they get up out of bed? Talk to your patient and find out all of these things. You know, when you go home, when your patient is getting ready to go home, make sure you've talked to them about the things that they have around their house. You know, if you're sending your patient home and they have a walker, one of the best things that you can do is ask them, do you have what are those things called? Floor rugs. Rugs. Make sure they have rugs. If they have a rug in their house, that could be a safety hazard for them, because while they're walking around, just in case they don't get that walker all the way up on top of that rug, they could fall, okay? So we want to make sure that we've discussed all these things with your patients so that, you know, we can reduce the risk of falls and injuries as much as we can. Right, so we still want to promote this early activity and exercises. If you're in the outpatient setting, like you're in a clinic or something, these exercises, activities, they cannot be delegated to your CNA. These are things that nursing must take care of. So just be mindful of that, unless in your particular clinic, you give that delegation to that person and they're sufficiently trained. When I worked in a clinic, one of my CNAs was amazing. He worked in the Army, or not worked in the Army, but he was in the Army for I don't know how many years. So anytime we had a patient need a splint, finger splint, any kind of splint, we would send them to him. So for that instance, you know, he was properly trained and knew exactly how to do what was required. So we would always send our patients to him. That was only in that setting. So just be sure that you're up to speed on what goes on in your facility as to what you can delegate when it comes to ambulating, using crutches and things like that, okay? All right, so now we're gonna promote some early activity and exercise for a patient. It's the same thing that we do for every other thing that we do. Make sure you identify your patient, right? It's a great idea if your patient is getting up out of bed, it's a great idea to get a set of vital signs first. All right, we want to see what their baseline is. We want to see what, you know, what's going on, how they're doing, and move accordingly, right? If we're going to exercise our patient, we want to know if they have a history of exercising. What kind of exercises do you do? How long do you exercise, right? We need to know these things so that we can plan how we're going to work with our patient during that time, okay? Find out if your patient has social support, right? If Martha is in the hospital right now and she's going to be going home, does she have someone that she can call to come and help her, to be with her when she goes for exercise or when she goes around to ambulate or do any of those things? You know, is her daughter coming over? She got a best friend, Lucy, coming over? Like, what are we doing? Who's supporting her in this time? So we always need to know these things. And once again, I'll always stress, you know, make sure that physical therapy is consulted so that they can kind of devise a program for the patient as well. Because as nurses, that's not really our forte of devising a program for someone. That's not really what we do. but there is someone who can. It's the physical therapist. And so make them your friends if you have them in your facility, and that will make your job a little easier. Okay. Recommend strength training for adults. This does not mean by any means that we want all of our adults to be like, or older adults to be like, what's her name? She's old, she's like in her 80s, and she's like, she could beat me up, pretty sure. She could probably bench press a whole lot more than I ever could. She's a very strong old lady. I'm not saying that, but if your patient's going into the kitchen, grab a soup can, lift it up, right? Do something, right? And as we get older, our bone density may decrease, and we don't want our bone density to decrease because that could mean fractures for us. So any of that strength training using some type of weight will help to improve your strength and the bone density to prevent that from happening, all right? We can do balance exercises for our older friends because that will help to decrease the risk of falls. A lot of people fall because they just lose their balance. So if we do some sort of balancing exercises, walking heel to toe, leg raises, things like that, that will help them keep their balance, will help prevent them from falling. Okay. Keep measuring their heart rate during and after exercise, right? Compare it with the baseline, right? If their heart rate begins to get greater than 20% of what their baseline is, then you don't want them to continue. You want them to sit down. So make sure that you tell your patient that, so that we don't want to cause any other problems. So just make sure that you're teaching your patients that. Monitor your heart rate while you're exercising, which most people have a Fitbit nowadays, or a smartwatch of some kind. Even there's older people who have more of these technological things than I do, so it's pretty great for them, I suppose. So just let them know, hey, monitor your heart rate while you're exercising. If it's 20% more than what your normal heart rate is, then you'll need to slow down and take a rest break. Okay. All right. Quiz. The patient tells the nurse that she will not cooperate this evening with the physical therapist to perform exercises because she was in pain the entire time during exercise last evening. What question should the nurse ask the patient?
Did you receive payment?
She received payment.
Everybody agree?
Yes.
Did you receive pain medicine before exercise? Why would we ask that question?
Because if she's saying she in pain, then 9 times out of 10, she didn't receive any medication beforehand.
Absolutely. So that's pretty important, guys. If you've got your patient and you want to get them up out of bed, you want to have them exercise, ambulate, anything, make sure you medicate them first, okay? Because you don't want to make their pain worse, because it's going to be harder to get their pain under control. And then absolutely, she's not going to want to do anything. So make sure that you have assessed your patient prior to any ambulation, any exercise, and making sure that they are free of pain, or their pain is at a tolerable rate for them. Okay. Very good. Strong word. Excuse me. All right. So assisting with ambulation. All right. Make sure you're checking your orders before you do any of these things. If your patient is supposed to remain on bed rest, then assisting with ambulation will not be for you or that patient. Okay. So always check your orders. Your CNA, your nursing assistant personnel, they can help. They can assist with ambulation. Just know that, remind them to be safe about handling those patients. Meaning, if the patient is ordered to have a 3-person lift, then make sure that CNA has 3 people to help them lift. Or if the patient must ambulate with a wheelchair behind them, which is what we do anyways, especially if there's a patient who is unsteady in their gait, then we want to make sure that we inform our CNAs that are helping us, okay? Make sure that your patient, that they let your patient know to sit on the side of the bed and kind of let their legs dangle before they start to walk, right? Check their blood pressure before they ambulate, because if it's low, you don't want to get them out of bed because they might get dizzy and fall, okay? Let your CNAs or your nursing assistive personnel, let them know if your patient feels nauseated, if they get dizzy or pale, if they start to sweat, their systolic BP is dropped at least 20 millimeters of mercury within 3 minutes of sitting upright, they need to report it to the nurse immediately. And that patient does not need to be ambulated, okay? Make sure that they put on those non-skid socks or shoes, because we don't want our patients to fall and slip because they have a slippery surface on their feet. And we want to make sure that the floor is not cluttered, right? Some patients keep their rooms full of junk, right? And you can't even turn without bumping into something. So make sure if you're going to get your patient up out of bed that there's no mess around. Make sure they haven't spilled anything on the floor. We want to make it as safe as possible for our patients, okay? Anybody ever had a patient whose room was just junky?
Me.
It's terrible, isn't it?
I hate it.
Like, what do you need all this stuff in here for?
It's like, it seemed like the more stuff we took out, the more stuff she piled in there.
Yes. We had a patient at our facility last cohort, and he was just the cutest old man. He had probably the biggest room in the hospital, and he had everything in that room. He even had his room decorated. Like, he had a rug in his bathroom. Like, it was like, he wasn't there for a long term. He was just there for, like a week or two, maybe just to get some IV medications. But man, oh man, we walked into his room and it's like, is this your house? I mean, his nightstand he had a nightstand for one. It was all cluttered and filled with all the things. I mean, it was just something to see, should I say. But also, he was an engineer, and he had built his, oh gosh, what's that thing called? The little thing that you put your knee up on while you're walking to keep the pressure up off your foot. What's it called? You guys know what I'm talking about?
A scooter?
Yeah, it's like a scooter.
Yeah, that my mama got that when she had a knee surgery.
Yes, to keep pressure up off of that extremity when you're walking around, but it's not crutches, so it makes it easier to move around. He made his own because he was an engineer, so he liked to tinker with stuff. He made his own using a tractor wheel. Like, it had huge wheels. Y'all wouldn't believe it if you saw it. It's funny. Anyways, moving on. Right, so you're going to assist with your ambulation. Once again, we said you make sure you do all the things that you would do for any of your other patients. Check identify your patient, making sure you check that medical record to make sure of what their most recent activity was. You want to make sure that you see how far they walked the last time. We don't have to make our patients walk, 2 laps around the unit. If your patient just got out of surgery, let's just go to the door of the room, or let's just ambulate to the bathroom instead of using the bedpan. It doesn't have to be, 6 miles of activity or ambulation. We just want to make sure they get up and they move. And then maybe the next day or by the next 3 days, the goal would be to have the patient walk 1 lap around the unit. So you start slow and then you increase from there, okay? Make sure you're assessing your patient's vital signs. If anything's out of whack, especially your blood pressure, if it's too low or your pulse is too low or too high, you don't want to get your patient up out of bed. You want to wait until they are back to baseline, right? Make sure, like I said, if your patient needs 2 people to lift or a Hoyer lift or anything like that, make sure that you're following that patient's safe handling algorithm. So whatever is ordered for that patient, and it's usually ordered by the doctor, make sure you check that beforehand, all right? Also note if your patient has any orthostatic hypotension, any history of that. Anybody know what that is? Orthostatic hypotension?
Whenever their blood pressure drops from doing exercise.
When they get hypertension from moving. Oh wait, she talking.
Their blood pressure drops.
Yeah, it's so hard to hear you, Miss Castillo, but you're right. It's when Like you move from one position to the other, like if you're lying and you sit up or you stand up and your blood pressure drops, right? It used to happen to me all the time. That was before kids, though, before my regular blood pressure started being a little higher. But I used to get high orthostatic hypotension all the time, especially if I bend down to pick something up and then I stand back up. You stand back up, you get a little lightheaded, and you're like, "Whoa, I got up too fast." That would be your orthostatic hypotension. Okay, if your patient has this feeling, then you want to check with them first, of course. Just let them know, do you get lightheaded if you go from one position to the next rapidly? If that happens, for that patient, you want to have them sit on the side of the bed before you get them up to ambulate them. Okay. Right. So just make sure that they sit there for just a little bit. Once they're lying down, have them sit up and have them sit there for a little bit. Get their shoes ready, put the gait belt on, talk to them for a little bit, make sure the room's not cluttered. Just let them sit there for just a little bit so that, it's not an immediate get up from lying down, sit up, stand up, and then a potential fall. Okay. Right before you start to help your patient ambulate, you want to make sure that you're assessing their range of motion. Right? Can you move? It's pretty important. I need to know if you can move your feet, if you can move your legs. I need to know what we're working with before I get you up out of bed. Because if you can't move your legs, then there's really not too much I can do to help you here. Right? So you want to assess these things. You want to make sure if your patient is allowed to bear weight. Let's just say they had, I don't know, a surgery on their left leg. So you need to go in there with the idea that they may not be able to bear weight on their left leg. Okay, so you need to know these things so that you know what to do when you're helping your patient with ambulation. Okay. All right, so if we're going to ambulate our patient, what would we expect to happen? Like what do we expect to see with our patient? It's on the
They're
screen.
not to fall.
Absolutely. If I'm going to ambulate you, I expect that you won't fall, right? I expect that your vital signs go back to baseline after you've returned back to bed. Those are things that I expect. What are some unexpected outcomes?
A fall.
A fall, absolutely. Falls, injuries, a drop in her blood pressure, dizziness, things like that. Those are unexpected. We don't want those things to happen when we go to ambulate our patient. Right? So if we're ambulating our patient, make sure you provide privacy. If your patient's in the hospital gowns don't have backs if they're not tied properly. So make sure you put something else on top of that patient to cover them. And usually what we do is they'll have on the regular gown and there may be that opening in the back. So we'll take the gown, another gown, and put it on like a robe so that we're at least covering their backside, right? So make sure that you've provided privacy for your patient. Organize all of your equipment. There's been many times when I've gone to ambulate my babies, especially after surgeries, and I call my babies anyone under 18, so it could be a 12-year-old. But if I go to ambulate any of my babies, just in case they have a lot of equipment, because some of them have multiple IVs, multiple IV fluids going, catheters, wound drains, anything like that, you want to make sure that if you need an extra person to help you ambulate your patient, get another person, okay? Because I can only handle so much and I need to be available in case my patient gets busy or something like that. So I'm available for my patient and I have an extra person who can handle all of the IV lines, the wound vacs, a chair or a wheelchair going behind the patient if we need it. So, just make sure of what you need before you start to ambulate your patient. All right. Organize that so that you're not halfway down the hallway and you're by yourself and now your patient's dizzy and you have a catheter and wound drains and IVs to worry about. Okay. So always just plan your care around when you can have an extra person available. Okay. If your patient is, if they wear the SCDs, which are the sequential compression devices, anybody know what those are?
Yes.
Squeeze your legs, alternate, like it's a squeeze and off and a squeeze and off. It's kind of squeezing your leg to make sure that your legs maintain, um, what's the word I'm looking for? Motion.
Proper circulation.
Proper circulation. Thank you. So, guys, did you know you can buy these on the Amazon if you go on a long flight to somewhere? It's true. If you decide to go to, let's just say, overseas somewhere, and you know those flights are pretty long, so you're stuck, you know, sitting down for a majority of your flights. They sell those SCDs on the on Amazon.
Oh, wow.
Indeed, it's a fantastic thing. Anyways, so you know, don't get a clot while you're flying in the air. You can get yourself an SCD machine and just keep it for when you travel. Right? Determine the best time for to emulate your patient. Right? Schedule all those activities around emulating your patient. So remember, if you have an older patient, you don't want to do everything all together. So if she's taking a bath, she may get tired after bath time. So it's not the best time to ambulate because she may get tired and may fall. So you want to, you know, schedule your best time to ambulate. So I say, you know, okay, she's going to take a bath in the morning. All right, she'll probably get tired. So how about we ambulate right before lunch? Right? So I'm planning my care around what she needs to do because I know, okay, I have these other things to do as well, but I know she'll get tired after the bath time. So why don't I schedule for ambulating her right before lunch, because that means she'll be awake, she'll be alert. Hopefully she's not hangry, and then we can get our ambulation done and then she can go eat lunch, right? And that gives your patient an incentive also. We're gonna walk around the unit, and then as soon as you're done walking around the unit, it's gonna be time for lunch, right? And she'll be like, oh yeah, that's great, okay. All right, ambulating, assisting your patient with ambulating. I'm gonna stop sharing for just a second because I do have a video that I can show you for this, because all of these words really don't make a whole lot of sense. So I'm gonna show you guys a video instead as soon as I get to it. And it logged me out. Please hold just one moment. Everybody doing okay? So quiet this morning.
Sleepy.
Sleepy?
Yeah, my allergies are picking up.
Yes. All right, so here is, this one is more of a patient that is transferring from the bed to the wheelchair, but just so that you can see the process, especially with the gait belt, because I'm going to show you guys this tomorrow. So this is explaining exactly what this slide, these next several slides, is telling you. Okay. Share my screen with you. Can y'all see that, or do you want me to make it bigger? It's okay.
Assist the patient to the side of the bed and turn the patient toward you. Then stand opposite his hips. Turn diagonally so that you face the patient and the far corner of the foot of the bed. Create a wide base of support by spreading your feet apart, with the foot that's closer to the head of the bed in front of your other foot. Then slip your arm, the one closer to the head of the bed, under the patient's shoulders to support his head and neck. Place your other arm over the patient's thighs. Move his lower legs and feet over the side of the bed by pivoting toward your back leg, allowing the patient's upper legs to swing down. At the same time, shift your weight to your back leg and elevate the patient on the side of the bed. Help him move to the edge of the mattress. Let him sit on the side of the bed, legs dangling, for a few minutes before transferring him to the wheelchair. Do not leave him unattended. Help him put on non-skid footwear and place his weight-bearing or stronger leg forward with his weaker foot toward the back. Then place the transfer belt around his waist, over his gown. With the tag on the gait belt touching the patient's gown, slide the metal trimmed end of the gait belt through the teeth on the other end. Pull the metal trimmed end away from the teeth. Tighten until snug on the patient's center of gravity. It should be tight enough to only allow 2 fingers to slide.
Now I want it to be snug enough that it's secure, but not so snug that you can't breathe.
Spread your feet and flex your hips and knees, keeping your knees aligned with those of the patient. Grasp the transfer belt along the patient's sides. Be sure to position yourself slightly in front of him to guard and protect him throughout the transfer. On the count of 3, rock him up to a standing position by straightening your hips and legs, keeping your knees slightly flexed.
1, 2, 3.
While rocking the patient with a back and forth motion, make sure your body weight is moving in the same direction as his. Then ask him to push up off the mattress, unless doing so is contraindicated. If needed, maintain the stability of the patient's weak or paralyzed leg with your knee and pivot on the foot that's farther from the wheelchair. Tell the patient to feel for the edge of the wheelchair against his legs and use the armrests for support as you ease him down into the wheelchair.
All right, so that's basically what you're doing when you're using that gait belt, which, like I said, we'll do tomorrow. The one thing that she didn't say in the video that she was doing was make sure if you're transferring a patient from the bed to the wheelchair, make sure that the wheelchair wheels are locked. All right, because if they're not locked and your patient is trying to feel for the wheelchair behind them, then the wheelchair will roll and then you have a patient fall. All right, so make sure that you are paying attention to that. All right, where were we? Oh dear. Where did we go? There we go. Okay, so, like we do with all the things, before you start with that, you want to make sure that you are washing your hands. Like I said, make sure that patient sits on the side of the bed for a little bit, put the gait belt on. Has anyone ever used a gait belt before?
I don't like it.
You don't like them?
Mm-mm.
Why not? Please tell.
I just don't, because every time that I use them, I feel like I have a better support if I'm like actually holding on to the person than I do holding on to that belt, because I just feel like it's gonna slip off.
So yeah, I like them. Once again, PD nurse, so we didn't really have to use them. We could just pick up our kids and put them on the floor, or move them wherever we needed to. But I think they're great for safety purposes, right? It's something for you to grip onto if you need to. So they are wonderful things to have. You guys have them in your nurse packs. So make sure that you bring your nurse packs when you come tomorrow and Friday, because they are in your nurse packs. Okay. Like I said, I'm not going to really go over each and everything here because it doesn't make sense at some points, just to tell you as opposed to showing you. And since I can't actually show you in class, I have to show you the lovely videos that I find. Which this one, again, assisting with ambulation. This one is more with helping your patient walk. And I forgot that I have another video. Please hold. All right, and this one is going to be assisting with ambulation. All right, so this one's actually walking walking your patient. All right, so I'm going to share my screen here. Another short little video that helps kind of put all the words on the paper it helps it make sense. Cause I mean, I don't even want to say all these words on this paper because it doesn't make sense if you can't see it in action. So this is the next several slides. This is what it is, assisting with ambulation.
Okay, we're gonna go ahead and we're gonna get you up out of the bed.
Lower the bed as much as possible, and then lower the side rail nearest to you. Slowly help the patient into the Fowler's upright position. Stand on her stronger side unless she is using an assistive device, such as a cane, walker, or handrail. Then stand on her weaker side. Help the patient sit on the side of the bed for a moment, dangling her legs and taking a few deep breaths until she gains her balance. Help her into her robe.
Let's get this robe on you.
Ask her to move her legs and feet up and down in a circle. Then help her put on non-skid slippers or shoes.
And how about your left foot?
Okay.
There we go.
Okay, Linda, let me go ahead and get the gate.
Ask her if she feels dizzy or lightheaded. Then secure the gait belt, making sure the fit is snug.
Feel nice and snug?
Yes.
Good.
Grasping the gait belt near the midpoint of the patient's back, help her to a standing position and observe her balance. Ask her again if she feels dizzy or lightheaded.
And stand up. Good. Let me get you all nice and straightened out. How are you feeling?
I feel fine.
Dizzy or lightheaded?
No.
Good. Okay, go ahead and grab your cane.
If needed, make additional arrangements. For instance, for a patient with a continuous IV infusion, obtain a portable IV pole for ambulation. If the patient has a urinary drainage bag, be sure it is carried below the level of the bladder and that there is no tension on the tubing.
Okay, we're going to take a step.
Have her take a few steps as you stand on her stronger side. Or, if the patient uses an assistive device, stand on her weaker side instead. If the patient becomes weak or dizzy, immediately return her to the bed or guide her to a chair, whichever is closer to her.
And left leg. And your right. Good. How are you feeling?
It's beginning to feel a little lightheaded.
Okay, let's go ahead and get you back into bed. Can you step back with your right leg? Now the cane and your left leg. And your right leg. Good. And the cane and your left. Good. And nice and down. Good. And let's just sit here a minute until the dizziness passes, okay?
Okay.
How are you feeling now?
I feel okay.
Dizziness gone?
I think so.
Okay. Let's try that again, okay?
Okay.
Let's go ahead and stand up. Go ahead and push off from the bed.
As the patient steps forward, grasp the gait belt behind her back near the middle. Take a few steps forward with her, assessing her strength and balance.
Now your left leg and the right. Good. Cane. Good. Bring that right one.
All right. Does that help a little bit, guys, instead of just reading words off of the paper, off of the slides, to kind of show you how you should ambulate your patient?
Yes.
Very good. All right. We'll go through these next. Hold on. Share my screen. There we go. All right, so this is what we just discussed. Your IV line, put it on the same side as your infusion site, like she said. If your IV is in the right hand, then put the pole with the IV fluids on the right side. Foley catheter, make sure the bag is below the bladder, because if you don't, you can cause the urine that's been in the bag or in the line to reflux back into the bladder, and you can cause your patient to have a UTI. So make sure that when you're ambulating your patient with a Foley catheter to keep the bag below the level of the bladder, okay? All right, this is just another video, and this is on your PowerPoint as well. So you can go back and look at this one, and it's just another with the lady helping out with the gait belt and helping the patient to ambulate. So it's there in the event that you would like to watch it. Okay. Which number am I on? Hold up. 34. Sorry, guys. I lost my page numbers. Here we go. All right. Once you're done evaluating assisting your patient with ambulating, make sure you evaluate them. You know, if they're tired, if they have more pain than they had when you first started, monitor their vital signs. And, you know, just kind of have them tell you, okay, today we ambulated from the bed to the door to the room, and I got really dizzy, but now in the future, if I get really dizzy, I'll just sit back down and then we'll try it again later. You know, just kind of evaluate how your patient did with walking, okay? Now, this is always fun times if your patient starts to fall while they're walking. I say it's fun times, but it's not. There's a safe way to help your patient to fall so that you can prevent massive injuries, you know, from happening unless they fall forward and you're standing, you know, slightly behind them. So you want to help lower your patient to the floor if you're walking behind them, and then stay with your patient until help arrives. Don't leave your patient. Okay, call for help if you need to. Anybody ever been at work when a patient's fallen and you were right there with them? Yeah, it's not fun. There's a lot of paperwork. Right, you got to make sure your patient's okay, and you know, you got to do vital signs. You got to let the physicians know. You need to let the managers know, the family know if there's family involved, and you have to do an incident report. Lots of documenting. Make sure you assess those vital signs. So if your patient is falling, this is what you will do.
He starts to get weak and starts to fall forward. I'm going to not try to stop his fall, but I'm going to widen my stance, pull him close to my body, and ease him down to the floor to try to break the fall. Okay? And then I would immediately get the nurse, and we would.
Oh, you can't see it?
No.
Please hold. Sorry about that.
Pull him close to my body and ease him down to the floor to try to break the fall. Okay? And then I would immediately get the nurse.
But you are the nurse.
We would assist him, make sure that he's all right. Okay? Check for injuries. Okay. I'm going to go ahead and walk.
Kind of bad acting, but you can see where she didn't just let the patient just fall to the floor. She kind of guided him down, and that kind of broke the fall a little bit. So he didn't have, you know, a broken hip or something afterwards. So she kind of let him slide down her leg so that the impact of the fall wasn't as bad as it could have been.
She still have to do an incident report if she
Yes,
did
she
that.
does. Yes, she does. It's still a fall. So absolutely, you still have to do the incident report if your patient falls, but you've hopefully prevented your patient from getting any serious injuries from kind of helping guide him down to the floor. Okay, so if you find your patient on the floor, right, make sure you get a set of vital signs. So, you know, if you know your buddy down the hall is working with a patient and you notice that the patient falls, you know, be a good friend, go grab a vitals machine and come and take the patient's vital signs for them, right? Check for any injuries. You know, old folks, check to make sure they didn't break a hip, make sure no arms or wrists, no skin breaks, things like that. You want to make sure there's no injuries on the patient. And then you want to assist them to the bed or up into the wheelchair, or whatever you have close to you, okay? to get them up off the floor. Call for help if you need it. And then you're going to notify your healthcare provider, right? I just want to let you know that patient blah, blah, blah has fallen on the floor. These are the vital signs. I see no obvious injuries right now. She is complaining of a headache at this time. So you want to make sure that you report what happened to the healthcare provider so that in the event, oh, you said she's got a headache, did she hit her head? You know, in the event that she did hit her head, they may want to do some x-rays or CTs, MRIs, something so that they can assess and make sure there's not any damage going on. Okay, so you notify the healthcare provider. You want to notify the floor manager, whoever is in charge on your unit. You want to let them know that there's been a fall. All right. If allowed, if there's permission given, or if there's, you know, a next of kin or someone with the power of attorney or a guardian, then you want to notify that person as well. Okay, because I'm pretty sure there's been instances where patients have fallen while they've been in the facility and nobody told them, right? And then come to find out the patient has a broken hip. So you want to make sure that you're reporting this to the person, whoever is in charge of their care. And then of course you want to do an incident report. Okay. All right, let's take a break and come back at 10:10. Alrighty, everybody back? We'll go ahead and go back to our falling man. All right, make sure everybody signs back in and go live on camera for me. All right, so we've seen how to ambulate our patient and assist our patient if they start to fall. What do we need to do if we find a patient who has fallen?
You said you found one that is falling or that already fell?
Someone who's already fell.
You need to make sure that they're okay, and you need to get help. But first, you gotta assess them first. Make sure they don't have nothing's broken and not bleeding or whatever before you move them.
Okay, and then what else should we do? Oh, I
Notify
see.
the charge nurse.
Say what, Mr. Aaron?
Notify the charge nurse or whoever's in charge.
Notify the charge
Physician.
nurse. There's something else we should do before that, though.
Vitals.
Vital signs.
Document vitals,
Vital
assess,
signs.
and put him back in his bed.
Very good. Do all of the things pertaining to the patient first, and then go about doing all of your notifying everyone and documenting. So assess for injuries, make sure they're okay, take their vital signs, get them moved back to bed, and then notify your their doctor, their physician, the charge nurse, their family member, and then document the entire incident. Okay. Most places have a form that you'll fill out if there is a fall. So just become familiar. They'll tell you exactly what it looks like, exactly how it should be filled out. Most places will even have an example of what you should put on there, just to make sure it's crystal clear. Okay. Right. So if you've been walking your patient, you want to make sure you document it, of course. We want to know how far a patient walked, how they tolerated it, if they got weak at all, if they ended up fatigued, severely fatigued afterwards, how their balance or gait was, if they have pain, and any changes in their vital sign. So make sure that you document those things. So you would say something like, we're in the patient's chart already. So ambulated patient from bed to, I don't know, to hallway, to hallway. Okay. Patient tolerated well, no complaints of pain during the ambulation, no onset of weakness, no fatigue noticed. Patient did complain after we're being returned to bed and was medicated for that. And patient's gait was steady. Okay. I would typically report, if I'm going to do this, if I'm going to report before and after here, I would typically report vital signs before ambulating patients were blah, blah, blah. And upon completion and returning to the bed, patient's vital signs were blah, blah, blah. So that we can see and compare if we need to, compare and contrast. Okay. Make sure that you hand this off to the next nurse or the nurse in charge, whatever happens. So if there's expected outcomes, the patient did great. Maybe the next time when you go to ambulate them during your shift, can you walk them a little further? All right. So make sure you give a good report when you hand it off. If there was an unexpected outcome, make sure you tell the appropriate people and tell your oncoming nurse, patient fell while we were ambulating in the hallway. I was able to guide her down, but she did hit her head on the side of the wall. So she's been complaining of a headache, just monitor her for that. So make sure that you report off appropriately to the next person, either coming on shift or if there was an unexpected event happen like a fall. Okay. Okay. All right, range of motion exercises. What are these?
Flexing and extending the arms and legs.
Yes, this is so that our patients can maintain mobility in that joint, right? So if you have a patient, if we're getting older, we go to the hospital, let's just say I'm confined to the bed, right? I don't want my hands to stop moving. So or my legs or my feet. So just because I'm not getting out of bed walking, I don't want those muscles that are involved with walking to not work, right? So you want to do some range of motion with your patient, or I would want someone to do range of motion with me if I were in that situation, right? So this is going to preserve flexibility and mobility in the involved joints. Have you guys seen patients before where there was no range of motion performed and the patient got super stiff? No longer able to hold on to things, can't grasp anything. So those things
If
happen.
you don't use it, you lose it.
Absolutely. If you don't use it, you lose it. My little patient that had his bathroom all decorated and everything in the hospital, he was big on moving around because he said motion is lotion, right? So if you're not moving, your joints and things can't get lubricated. They can't move as easily as they would be able to otherwise. But if you're moving around, then it's like lotion. It helps everything glide easily. So that's kind of how he explained it. He was a very eccentric man, to say the least. Right? So there's different types of range of motion exercises. If it's an active range of motion, the patient can do it themselves. They can move independently. So you can say, all right, Miss Johnson, move your wrist in circles. Do some wrist circles. There you go. Look, I didn't even expect you to do it. Look at you. Thank you, ma'am. Right? So your patient could do it actively, right? I don't even have to help her. I just tell her, go ahead and do this for me. If it's passive, then the patient is completely unable to perform the motion because they're too weak or they're sedated. Maybe they're in a coma. Okay, so if your patient has passive range of motion, that means that you do the motion for them, right? So you physically, if we want to do some wrist circles, then you would physically hold their wrist, hold that area, and move their hand around yourself, okay? Because your patient cannot do it, okay? And if it's active assisted, your patient can assist you, but they need a little bit of help to complete those movements, right? Like she can move her arm, but she's not quite able to get her wrist to go in the circle. So you just have to kind of help her out a little bit, okay? So that's the difference between the three of those, and you'll need to know which one before you go in the patient to do range of motion exercises, right? Because if I can do active range of motion exercises on myself, and you come in and start grabbing my arms and try to do the exercises for me, I'm probably going to look at you sideways and probably gonna tell you to get out of my room. Okay, so always assess your patient first and determine which one of these range of motions would apply to them. Okay. Right. You can delegate this to your CNA or to your PCT or whoever your nursing assistive personnel is. Make sure that they know to go slow, right? This is not a marathon. Wait, no, that's not the right phrase I want to say. They don't have to be quick, right? This is not, you go in there, we're going to be Speedy Gonzalez, hurry up and move these joints around and then we're leaving. You must take your time, okay? So this is not something to be rushed through. Make sure that they know not to exercise those joints beyond the point of resistance. So if your patient physically is unable to move their wrist to the side, then don't make them. That's what that means. So they need to make sure that they're aware of this, okay? And make sure that we know the patient's limitations or any existing conditions like arthritis that might already affect their range of motion, okay? Because all it's going to do is frustrate each person if they're trying to make them do exercises and they can't. So always be sure to let your nursing assistant personnel know that. Okay? For the first time for range of motion, usually the nurse should be the one doing it so that you can get a good assessment of how the patient is, right? It's either nurses or the physical therapist so that they can help devise a plan for them as well. All right. Same thing we do with everything we do to our patients. Identify your patient, check their orders, check any of their physical assessments and their histories to figure out what's going on, right? Find out if there's any range of motion restrictions, right? So maybe this patient is not allowed to lift their arm above shoulder height, right? Maybe, I don't know what might be going on, but maybe they're not allowed to. that's going to be written in the order, and you would have to adhere to this, right? Because you could cause further injury if the patient does lift their arm all the way up and they've been ordered to only lift it to shoulder height. Okay.
They can have a torn, what is that thing called? Ain't it a torn cuff or something like that?
Uh-huh. A torn rotator cuff. Uh-huh. And you do not want to lift your arm all the way up, right? So just make sure that you're reviewing those things before you start, right? Don't rely on your patient, because some patients don't want to do the activity in the first place. And they may tell you, no, I'm not supposed to lift my arm up at all. No, that's not what the doctor said, ma'am. You're supposed to lift your arm up to shoulder height, and then we just do exercises like that. So don't rely on your patient to tell the truth all the time, because they just might not want to do whatever it is that, is supposed to be done. Okay. All right. Make sure you're paying attention to their joints. If you notice any redness, any swelling, warmth, any obvious deformities, make sure you make a note of that before you start. All right. So that just in case you didn't realize that the patient's shoulder blade always sticks out, and then you go to do range of motion and then their shoulder blade's sticking out, and then you freak out because, oh my gosh, their shoulder blade's sticking out. Well, had you realized beforehand that their shoulder always sticks out, then it wouldn't be a problem, right? So always get your baseline for your patient before you start anything, okay? Right? Assess your patient's level of comfort. Make sure they're not in pain. If they are in pain, give them some pain medicine. Let it sit on for about 30 minutes before you start any exercises, okay? All right? Yay, it's video time, guys. I know you're so excited. I just have so much fun finding these for you. You're welcome.
If you manage a team, you have to try Monday.com. Monday.com is a platform to...
Hold on. New share. Hold up. There we go.
track everything your team is working on. We use it for...
We may skip to the good part.
Comfort to let you know you can go ahead and start with the exercise. It's very critical, okay, that you have to exercise the full range of the joints. So what I'm doing is I'm supporting underneath.
I'm pausing because this is bothering me. Anybody see anything wrong with this video so far?
She don't have no gloves on.
Well, this is true. She didn't have gloves on. There's one more thing.
Oh, the bed's low.
Absolutely. She's bending over to do this. So guys, remember, whenever you're doing any care on your patients, lift the bed so that you can save your back. Okay. Okay, I'm done. I'm off my soapbox.
Underneath her wrist joint and underneath her elbow joint. My hand is touching the bed. If your hand is not touching the bed, you will not receive credit for this step because you're not exercising the full range of the joint. You're going to perform each exercise 3 times, and you're going to do it slowly. All right, are you ready? I'm ready. All right. Now, when you extend or flex her arm upwards, you want to make sure that you flex it to the level of her ear, okay? So basically, her arm should be touching the pillow. You want to maintain support underneath the joints. That's 1. How are you feeling? Okay. 2. Okay. And 3. You're feeling okay? All right. And that will complete the first exercise, extension and flexion of the...
I'm not going to show you guys this whole video because I think, you can kind of get the gist here, where you want to make sure that you're supporting the joint that you're moving around, or of the extremity that you're moving around, right? So that you don't cause any injury. And you notice how, my arm doesn't go all the way, everywhere, but you want to make sure that you're keeping that patient comfortable, all right? You don't want to cause them extra discomfort by trying to move their extremity in a position that it doesn't go in naturally, okay? Like I said, always go slow, don't rush them, right? And here's a couple of exercises you can do with the feet. You can do with the knees, the hands, like we said, moving those wrists around, the fingers, because they tend to get stiff over time. So these are especially important when you have either older patients or when you are dealing with someone who has had a stroke. All right, we want to keep them mobile. If they start PT pretty soon after their stroke, sometimes they can get pretty good mobility back to that area if we've caught it early enough. So you want to make sure that you're providing that range of motion exercise for your patient. It doesn't take long. You don't have to do a million reps. This isn't like a, a mini exercise, a long exercise workout or anything. This is just something, if you come in the room, you're turning your patient, move their extremities. You don't have to take all day. You can pick an extremity each time you come into the room. It doesn't have to be all at the same time. All right. All right, you do these in a head to toe sequence. So don't start at feet and then work your way up. Just start head to toe like you normally would. As opposed to what our little friend just told us to do it 3 times, we want to exercise this 10 times. Okay, or you want to move it to the point of resistance and hold it for 30 seconds. Okay, so we want to make sure that we're loosening those joints. Motion is lotion. All right. Let the patient know how these exercises can be incorporated into their ADLs. If your patient's at home, all right, I know that, you've been having problems grabbing things. Your grasp isn't as strong as you would like for it to be. So just practice, go to the cabinet, to the pantry, grab a can of soup, put it back, grab a can of soup, put it back. You're working out many things when you do that, right? Quick quiz, right? An 82-year-old man with a rotator cuff tear is not a candidate for surgery, right? They're just going to let this heal on its own. Which of the following exercises can the nurse teach the patient to do to assist with their range of motion?
Reach to the bedside table to lift a book.
Boom. Everybody agree?
Hold on, I'm still reading.
Oh, my bad.
See.
See?
Yes.
We don't want Grandpapa to be lifting those 15-pound weights.
Too heavy.
It's too heavy, right? It's not appropriate for him, right? So I'm guessing that 5 count sets of push-ups aren't appropriate either. And should he be changing those overhead light bulbs?
No.
No, right? Because that's putting his arm in a position where he can do more damage. So absolutely, just reach to the bedside and get a book off the bedside table, right? It doesn't seem like an exercise to you or I, but it's working out that extremity. It's keeping it mobile, okay? So, and it's not going to cause more stress to the injury that he's already got, okay? Beautiful, strong work. All right, these are every nurse's favorite thing, said no one ever. All right, anti-embolic compression stockings are like the devil. All right, anybody ever put them on somebody before?
Yes. Yes, I have, and I learned how to put them on so that it's not so difficult.
Well, please tell us.
I just work my way up. Like I have to roll it all the way down and then put it on and start like pulling upwards.
Yeah.
You're talking about TED hose?
TED hose, yes, ma'am.
Yes.
Yeah.
TED hose are the devil. I hate to see an order with TED hose on them. Luckily, I don't see it very often. In PD land, it's not something, kids, they're so resilient. You give them a surgery and sometimes they just bounce back like nobody's business and you have to tell them to sit down. So, I typically don't have to see these things very often, but sometimes I do. So we use these things for preventing deep vein thrombosis. All right. Have you guys talked about this in A&P at all?
Not yet.
Not yet? Okay. So you will. If not in A&P, you'll definitely talk about it in Med-Surg next semester. So what this is we're talking about a DVT, deep vein thrombosis. A thrombus is like when there's a bunch of platelets, some fibrins, all those clotting factors, they just kind of accumulate together and then they attach to the wall of a vein or an artery. And then they can occlude that vessel so nothing else can get through. So if your patient has this, you're going to notice some swelling. If it's in their leg, you're going to notice swelling. It's going to be warm to touch. Their skin might turn a little bluish, and they're usually going to have pain. All right. So if you have a patient and you notice any of those symptoms or those signs, then you might want to let your provider know. Let them know, hey, patient's complaining of pain in their calf. The legs are not the same size. One is swollen, one is not. One is warmer than the other, but it's a little bit blue tinged. I think they may have a DVT. Okay, so if we have the feeling that our patient may be predisposed to having a DVT, then we want to put on some of these anti-embolic compression stockings or TED hose, as you'll hear them called, or a sequential compression device, right? And what that does, the compression device, it, like I said earlier, it just kind of puts pressure on, takes pressure off, puts pressure on, takes pressure off. It's very rhythmic. It's almost like a massage, but not quite. And we use both of these pieces of equipment if our patient is at risk for getting any clots in their legs, all right? They're also going to end up on some sort of anticoagulant therapy. So these people will be on blood thinning medications to reduce the chance of them getting a clot, all right? So these are the people that we have to be careful of. You know, let's try not to bump their legs into anything. Let's not use regular razors to shave them. We want to use electric razors, because if we use a regular shaver and we cut them, they may have a hard time stopping the bleeding occurring. Okay. So the stockings are, like we said, they're kind of difficult to put on, especially if you've never done it before. We may have some in the lab. I'll check tomorrow in the morning when I get there to see. We may have some, but we may not. I think we do, but of course it's going to be pretty easy to put them on the mannequins. While we're speaking of the compression stockings, ladies and gent, before you start your nursing careers, please get you some compression stockings, because when you're up on your feet for 12 hours a shift, you never, well, let me just say, you don't want varicose veins to happen, right? I learned kind of sort of the hard way. I have a couple of little friends on my legs that I'm not really too proud of, because I should have been wearing those compression stockings, working 12-hour shifts without really sitting down ever. So save your legs. They're super cute nowadays. You can go on Amazon, you can get on the Groupon, you can go to the scrub shops, but please wear them. All right, they will save you. Oh, Miss Brockers. Oh, wait, where'd she go? Hold on, you're not on my screen. Oh, yes. What she's got, Miss Brockers has got it. She showed it up. Thank you, ma'am. Guys, get you some, right? Because I'm telling you, this is, they're lifesavers. And you feel better at the end of your shift, right? Anyway, I'm off my soapbox on that one. All right. You can delegate this to your nursing assistive personnel, all right? Remember that they come off, you take these things off, either the compression devices, the SCDs, or the TED hose. They're to come off before the patient gets out of bed, right? So our patient's not going to be walking around with them on, to make sure they know this, okay? Make sure that your CNA or your nursing assistive personnel reports to the nurse if the patient complains of pain, if their leg is swollen more than the other, if it's red, if it's hot, if it's tender. Please make sure they know those signs so that they can report it to you, okay? Make sure that they know to tell the nurse if the patient continuously takes their compression devices off, okay? Because we're putting them on them for a reason. And if the patient's continually taking them off, we may need to give them a little talking to, okay? Most of your TED hoses come in different sizes, so make sure that you measure your patient's legs appropriately. The size is usually written on the package, and you can tell which size based on the measurement of your patient's leg so that you don't get some that are too small for your patient or too big. If they're too big, they're not going to do anything. Okay. All right, so you'll need your tape measure, and that is so that you can measure the leg. Our friends in Bookland said that using some sort of powder or cornstarch is helpful for putting them on, helping them get on easier. You'll need your compression stockings if you're using the TED hose, or you're going to need the Velcro compression device sleeves if you're using the SCD. You'll need the pump. And those, I mean, if you're using the SCDs, they're very easy to operate. You basically put the Velcro sleeves on the patient, hook it up to the machine, and then turn it on. That's it. It's not hard, right? So make sure you have an order for either of these things before you do anything. Don't just go get them and put them on your patient. Make sure you have orders for them, all right? Like we do with everything else, make sure you identify your patient, all the things. There is a scoring sheet that you can use. It's called the Well Score. It's in your textbook, box 18.2, if you should look at it. But it will give you the scoring guidelines for your patient who may need these, right? What do we think might be some contraindications for using either these elastic stockings, your TED hose, or your compression devices?
What was the question?
What do you think would be a contraindication for using either the TED hose or the compression device?
Swollen legs or feet? Is that what you mean?
Is it a contraindication?
Yes.
Oh. Cutting off circulation?
Skin tears.
Skin tears.
Oh.
Absolutely. So if our patient has any wounds, any open lesions, we may not want to use these TED hose or the compression devices, all right? This person may just need more range of motion exercises, right? If your patient has had a recent skin graft, we cannot use these at all, okay? Because that will mess up the integrity of the skin graft, right? If your patient has gangrenous or cyanotic or cool extremities, we probably don't want to use either of these as well, all right? So make sure that we're inspecting the patient's skin prior to putting them on. This is absolutely the time, guys. If you're going to put lotion on your patient's skin, this would be a great time to do so, because this is when your cloud of skin comes off when you're taking off these socks. So it's a good idea to make sure that you are hydrating your patient's skin prior to this, right? Make sure you let the patient know what you're doing if you're going to use either the TED hose or the SCDs, right? Don't just go in there with a pair of pantyhose, is what they look like for the men especially. Like, I'm not putting that on, I don't know what you're doing. So make sure you explain to the patient what's going on, what you're doing, why they need them, okay? Right? Make sure you give them privacy, right? If your patient's got some dirty legs and toes, please wash them before you put the socks on, right? Dry them thoroughly. And then you're going to measure those legs, like I said, to make sure that you know what size stockings to get. All right? Video time, because this picture just doesn't do a whole lot of great things to show you how to put them on. Here we go.
If needed, bathe and dry the legs. To make the stockings easier to apply, you may apply a small amount of powder or cornstarch to the patient's legs in accordance with agency policy. To begin, turn the stocking inside out by placing your hand into the sock as far as the heel pocket, while you hold the toe of the sock with your other hand. Now, place the foot of the stocking over the patient's toes. Smooth and flatten the stocking before you continue. Slide the remaining portion of the stocking over the foot, keeping the toes covered. Make sure the stocking fits in the toe and check to see that the heel is in the pocket. Next, slide the stocking up until it's fully extended over the calf. Be sure the stocking is smooth and the fabric is free of ridges and wrinkles.
All right, look good? Sound good? Easier said than done.
Nursing students have a saying, the struggle.
She won't stop talking. That's enough. All right, here we go. All right, so putting them on, they want you to turn it inside out. Pull it in, you just saw our friend there. All right, slide it over the foot. Make sure there's no wrinkles or anything in it because you can impact the patient's skin integrity. If there's wrinkles and things in it, if they're just lying in the bed and they're not really moving around, that wrinkle can cut off some circulation. It could cause some pressure ulcers. So you want to make sure that you've got it nice and smooth when you put it on. Okay?
I've noticed on one of my residents, it's easier because she stays in a bed a lot, so her skin is dry. It's easier if I put cocoa butter on her legs before I put those on because it helps them to slide up easier.
Yes, it will help them slide up easier. And you don't have the plume of skin coming out of the sock when you take it off. It's great. Win-win situation. All right, so this is, now we'll talk about applying the sequential compression devices or SCD. All right, once again, I have my trusty handy dandy video because sometimes it doesn't make sense when you're just looking at words and pictures. So we'll go here to my friend, my same little lady.
After performing hand hygiene and providing privacy, introduce yourself to the patient.
My name is Lori. I'll be taking care of you today. How did you sleep last night?
Then verify the healthcare provider's orders and confirm his identity using 2 identifiers. Tell the patient that a sequential compression device, or SCD, has been ordered to improve the circulation in his lower legs. Position the patient supine and raise the bed to a comfortable working height. Explain that you need to check his legs for scratches and cuts before you can apply the device. Make sure the legs are warm and assess the pedal and popliteal pulses. Evaluate the patient for risk factors in Firshow's triad, which can contribute to deep vein thrombosis. Measure the patient's calves with a measuring tape to make sure you select the correct size SCD sleeve. Some thigh-high SCD sleeves require you to measure the length from the heel to the buttocks. Compare the measurements to the size chart on the manufacturer's package.
Back down, and I will be right back. All right, Mr. McDermott, I have the equipment. This pump is going to sit at the foot of your bed.
Remove the SCDs and unfold and flatten the sleeves on the bed. Some manufacturers require the use of stockinettes or elastic stockings under the SCDs. Refer to the manufacturer's instructions. Arrange the first sleeve under the patient's leg according to the position marked on the inner lining of the sleeve. Make sure the back of the ankle lines up with the ankle marking on the inner lining of the sleeve. Align the back of the knee with the popliteal opening on the sleeve. Then wrap the sleeve securely around the leg, making sure it is smooth. Check the fit. You should be able to slip 2 fingers between the leg and the sleeve. Now attach the sleeve connector to the plug on the mechanical unit by lining up the arrows on the connector with the arrows on the plug. Then turn on the unit. A green light indicates that it's functioning properly. Monitor the functioning of the SCD through 1 full cycle of inflation and deflation. Then perform hand hygiene and document the procedure in the medical record. As part of your follow-up care, remove the SCD sleeve at least once a day for as long as necessary to inspect the skin for irritation or breakdown.
All right. Does that help it make a little bit more sense there instead of just, me reading the slide and telling you? Right. So this is just these things are pretty comfortable when you put them on. We don't keep them for patient to patient. They're disposable. And this lining is pretty soft, so it's not going to irritate your patient's skin unless it's not put on correctly. You have this little hose here. It connects to the machine. And then you turn the machine on. I usually, if I'm in the patient's room, if I know I'm going to be in the patient's room for a little bit of time, I will, just to give them a little bit of break, I'll turn it off while I'm in the room. Let them take a little break, inspect the skin, make sure they're moving their toes and their feet around and everything, and then I put it back on before I leave the room. So just to give them a little break and, to inspect the skin like you need to do. She said once a shift, but I like to do it more than that because you never know what can happen in a 12-hour shift, right? So if you have a patient needing these, just make sure that you're inspecting that. No, ma'am, Miss Mamani, I actually was going to say something about that. Please put gloves on. I know all of these people in these videos have yet to put gloves on, but I don't want to touch other people's skin.
Please put gloves though, because that dead skin is nasty, and I don't know. Ooh.
Please put your gloves on. It's not cute. Most of the time, especially if they're older, you're going to notice dry skin on their lower extremities. So not just the feet, but the legs too. So, you do hand hygiene and that's great, but these people aren't putting gloves on. And I think you put gloves on. All right. You just do it. Great question, Miss Mamani. Thank you for that. All right. We've been through all of that. You plug it in, make sure it's there, plug it in, turn it on. It's not hard at all to put these on, okay? But make sure when you turn it on, make sure it's working. So like the lady in the video said, make sure that you stay there for a full cycle of the sleeves inflating and deflating, because it may not work. Everything's not foolproof here. Sometimes we pick up faulty equipment and you don't want to put on faulty equipment and it doesn't work, right? So you put the SCDs on, you hooked it to the machine, you come back and the patient's like, I thought you said this was supposed to be like massaging my leg. It's not doing anything. So your patient's been in here for a couple hours without anything happening. So make sure that your machine is actually working. Okay. Right. Like we said, assess that skin integrity, make sure we're explaining to the patient what's going on, what we're doing. Make sure that we report any signs of DVT formation, right? So what were the signs and symptoms of a DVT forming?
Pain in the leg, redness. I think it's if it feels hot.
Yes. Redness. One of your legs may be bigger than the other.
Swelling.
Some swelling. Pain.
Pain. And like a heat.
Heat. Yes. Yeah. I have in my nursing career, I have caught one DVT. Only one.
Does that include like when people have what is that stuff called, varicose veins? Is that the same thing?
No. So those are more surface related. So your DVT is going to be like inside. It's deep. It's a deep thrombosis there. So it's you probably won't be able to feel it. Right? Yes, it is a clot. Remember, it's an accumulation of all those clotting factors, some platelets, all the things have come together and they have stuck to the side of your vessel wall, whether it's an artery or whether it is a vein. So, but you probably won't be able to see it. You won't be able to feel it, but you'll see the signs and symptoms of a person having one. Okay.
What was the question?
What are the signs and symptoms of a DVT?
Okay.
All right. right? So we want to make sure that we're monitoring our patients for these, because if by chance they dislodge, they can become a pulmonary embolism and your patient could die with little to no warning. All right. So we want to be especially mindful and pay attention to these signs. If you notice them, we need to start, handling it as soon as we notice. Okay. Make sure your patient, if they're alert and aware and awake, make sure that you tell them the signs and symptoms to look out for as well. Right? Because, who better to tell you what's going on than the patient themselves? So, especially if they're going to go home at some point, they need to know what to look out for as well. Okay. Right. Now we move on to the use of canes and crutches and walkers. Fun times. Who uses these things?
Mostly older people.
What was that?
Oh, I said mostly older people.
Not only older people. I mean,
I said mostly.
I said people who handicapped, because I know I broke my ankle working at the fair and was on crutches for a month, and I hated it.
Yes. You break a limb, if you break, if you have fractures, if you have surgery. So it's not only the older people who have walkers. My little neighbor, a couple doors down, my daughter's best friend, she had cancer, bone cancer in her hip. So she had a hip replacement surgery. And so she was on a walker for quite some time. And then she moved up to the crutches. She never used a cane. But so it could be anybody. But who was it, Miss Talise? Was it you that said that mostly old people with walkers? It just depends. One of the people I graduated from high school with actually fell and broke his hip at the skating ring not too long ago, and now he's on a walker. And what I had said was, we too old to be at the skating ring with all these young whippersnappers, right? Anyways. So anybody who can't bear full weight on one or more of their joints or their extremities is who's going to be using a cane, a crutch, or a walker, right? If they're not stable, right? If they need that extra stability from using a walker or a cane, then they're going to use it. If they have pain when they're weight bearing, or if their balance is terrible, okay? We want to use these because we want to help to reduce the risk of our patients falling. If we can help it, we don't want them to fall, right? If your patient is to be using a cane, a crutch, or a walker, then typically you're going to have physical therapists teach them how to use the device correctly and safely, all right? But we as nurses also need to be mindful of and realize how these things should be used properly if we want our patients to use them properly so that we can see any mistakes. One of my pet peeves in life is to be out somewhere and someone's walking on crutches and they're not properly fitted, all right? So you guys will learn all the things of how to properly use these so that you can, tell your patients, hey, let me fit that for you. Let me change this, or whatever the case may be, okay? All right. You can delegate this skill to the nursing assistive personnel. They can assist the patient with this. Same rules, just make sure that they know to have the patient dangle their legs sitting at the bedside before they get up to ambulate. Report any of those signs if there's problems, if they're nauseous, dizzy, blood pressure drops, any of those things. Make sure the environment is safe. They put on the little socks with the non-skid surface on the bottom, or their shoes to make sure that they're not going to slip and fall because of having naked feet. All right. If your patient isn't ambulating for the first time, then you as the nurse is the one who should be performing this initial assessment with them. This should not be delegated out. All right. But if your patient's been on crutches for the last day or two and they want to get out of bed, then you can absolutely delegate that task to your nursing assistant. Okay. Right. Make sure that your patient has whichever assistive device that they're going to be needing, that their shoes are properly fitting, and that they're non-skid surfaces, right? We can't have Nana up in some stilettos trying to walk with a walker, okay? It's not appropriate. I know Nana's used to wearing her stilettos, but she got to let them go for right now, okay? So make sure that she's got appropriate, well-fitting shoes or slippers. Make sure that her clothes fit well. right? We don't want to have any pants that are hanging over the shoes, or dresses that are too long, because we don't want them to trip over their clothing while they're trying to walk with their assistive devices. Okay. And then you're going to do all the same things that you typically do. Identify your patient, wash your hands, all those things. Okay. What's our expected outcome if we're using any of these assisted devices for our patients?
That they use it without falls or hurting themselves.
Yes, that is number one. We want them to be able to use it without any injuries. We also want to make sure that they use it correctly, right? If your patient's using a walker, we want to make sure that they're walking properly with the walker, right? So make sure that you've explained and demonstrated this technique to them. Sometimes it's appropriate for you to take the walker and you walk yourself so that they know what they're supposed to be doing, right? Make sure if your patient's walking with either of these things that the tips on the bottoms are clean and they're dry, right? Because if you've got some rubber tips that are wet and you go to walk with them, then you're gonna fall, okay? So let's see. We'll take a look at this little video, and then we shall, oh yes, thank you, Ms. Mamani, for your tenderness, warm skin. That is for our DVT. Right, so we'll take a look at this video and then we'll take a break, okay? So this one is, honestly, I don't remember which one this is. There's been so many. It's overload today. Cane and crutch walking.
When assisting your patient with cane walking, you want them to advance the cane, then their weaker leg is going to advance. They're going to be using their arm to help support them because this is their weaker leg, and the stronger leg will advance. They'll continue with the cane moving forward, the weaker leg. Now they're balancing on this cane because this is weak, and they're bringing their strong leg forward. So remember, the cane is always on the strong side of the body. When teaching your patient how to properly walk with crutches, you first want to make sure that the crutches are the correct height for your patient. When they're standing and the crutches are just to the side of them, you want to make sure that you have about 2 fingers width of space between the top of the crutch and the armpit. If it's any higher and the patient is using the axilla to hold up their body weight, they could cause nerve damage. You want to teach them that it's important to keep their elbows straight and locked when they're advancing. That way the pressure is on the hands, not on the armpit. Your patient is non-weight bearing on their injured limb. They're going to place the crutches approximately 12 inches in front of their foot. Then they're going to swing through and then advance the crutches. They will swing through and advance the crutches. For 3-point crutch walking, your patient is able to bear weight, but it's not very strong. So they still need the crutches to assist. I'm going to place the crutches 12 inches in front of my foot, put the affected foot forward. Using the crutches, I'm going to swing through with my good leg. Crutches 12 inches ahead, tap my affected foot, and then swing through with my good leg. When teaching your patient how to go up and down stairs using crutches, it's very important that you teach them properly to prevent them falling down the stairs. I'm partial weight bearing, meaning one of my sides is weaker than the other. When going upstairs, you want your client to first put their good foot up on the step, followed by the crutches coming up onto the step, followed by that affected foot. They'll continue to do so all the way up the stairs. When assisting your patient in going down the stairs, they're going to put the crutches down on the next step, followed by their affected foot, followed by the strong foot. The crutches will go down, the affected foot goes down, the strong foot goes down.
Oops, stop. Did that help? Kind of make a little bit of sense to you guys? Very good. There is, like I said, another video on.
You're not gonna actually have us play on crutches tomorrow, are you?
Yes, ma'am.
Do I have to play on the crutches?
I'm scared because I was always told if you play on them, you might break them, and I don't
Yeah,
want to be
I'm
in that
against playing on crutches, but for that exact reason.
I'm
Let's
real,
change
a walker or cane maybe, but
let's change the verbiage. We're not really playing in them. We're teaching you how to use them and to be able to teach your patient how to use them. Does that make more sense?
Do I have to actually be on them?
I mean, you can show your partner how to use them and make sure your partner uses them correctly.
Okay.
All right. So yeah, we'll show you guys how to fit them properly and everything tomorrow. There is a video, like I said, on your Canvas. It's about 16 minutes long, so I'm not going to show it to you guys here, but it's chock full of some really great information and tips on crutch walking, using a cane, and using a walker. So it would behoove you if you have 15 minutes out of your day to go and watch it. All right, let's take a break, guys. Let's come back at 11:15. Everybody back? I know it's a couple minutes early, but if everybody's back already, we can start. I think we're missing a few. I'll give them an extra minute, or the extra minute. All right, everybody back and signed in to the chat? All right, so we can wrap this up. Let's see, where are we? Did we just watch a video? I think we did. All right, so we'll just run through these next several slides really quick because I'm not going to spend too much time on the logistics of where to put what foot when we're not going to actually watch it because it's not going to make much sense to you. So we'll just kind of go through some of the pertinent things I want you to know, and then we'll go over that video. If I have time tomorrow, then I'll show it while we're in Skills Lab, right? If not, just make sure you watch that thing because it'll help give you a little clarity on everything, right? So the same thing that we always do, make sure you do hand hygiene, make sure that you have checked your chart to see what your patient should be using, if anything. For crutches, like the lady said in the video, they're not fitted properly if the top of those crutches is sitting right up underneath the person's armpit, right? If it's touching their skin, it's not fitted properly and it can cause nerve damage. So make sure that when you're walking with your patient with their crutches, when you're fitting them, they should not be touching the axilla, right? Most crutches nowadays, I'm sure even the wooden ones from the days of yore, have a little extender so that you can lengthen the crutch for taller people and you can make it shorter for shorter people. Most of them are by height. So I think the ones that we have in our lab they may be from like 5 feet to 5'7" or 5'8", I think. I could be wrong, but that's how they're sized. So if you have a super tall person, then you're not going to grab that particular pair of crutches. You'll get the size that goes up to 6 feet or whatever, right? Once again, when you're ambulating your patient, make sure they sit on the side of the bed first to kind of get used to being in the upright position. Have them dangle their legs for a couple of minutes, take their vital signs. Make sure you put a gait belt on them so that you can try to assist them if they need assistance, and you can help them to fall if they start to fall. Okay. If they're not steady, make sure you put them back in the bed.
You can use a gait belt on somebody when they're on crutches?
You can, especially when you're first fitting them for them. Now, I mean, not just because, you know, they're getting ready to walk around the unit or whatever, they're getting discharged or whatever the case may be, but those initial moments when they may be unsteady, you might want to put a gait belt on them. Okay. Right. Make sure that you're assessing your patient's ability to bear weight. Check your chart, check those doctor's orders to see what they want them to do. They will tell you non-weight bearing to left leg or partial weight bearing to left leg. You want to assess that first and make sure that you reviewed that chart so that you know exactly what the patient is allowed to do. Okay. All right. Before you get started with helping your patient to ambulate with the use of any of these devices, plan out how far you're going to make them walk or how far they can walk. All right. You know, it takes a little bit getting used to walking with crutches and even with a cane because there's a certain way you're supposed to do it. So I would say let's walk around the room first, get used to it, and then we can go out into traffic into the hallways, not traffic as in the road. Okay. But we can go out into the hallway so that they can maneuver well. make sure you schedule time for your patient, all right? Schedule time. Don't be rushed when you go to do this because you never know how fast or how slow someone's going to catch on to walking with these assistive devices. So make sure you schedule it in a time where you have time to do it, and make sure that they have enough time to take rest breaks if they need it while you're walking them, okay? Right? And so you see there's a whole lot of pictures here, and it just doesn't really make a whole lot of sense. So I'm not going to go through this. It is in your book. All of these are in your book, but I'm just not going to go through these because it doesn't, it makes more sense to see it done, right, than to look at it on paper. So we're just going to move on past these several slides here. Make sure if your patient is walking, especially if they're learning how to walk upstairs or just walking with their assistive device in general, and you have their gait belt on them, make sure you remain behind the patient, okay? It doesn't do you any good if you're in front of them. So make sure you stay behind them and hold on to that gait belt. So in the event they get unsteady, then you have a hold on them, okay? We're gonna keep going a little bit because our little lady just showed you how to walk up the stairs, and my little video will actually show you more, all right? Right? So when your patient gets these devices, make sure you stay with them when they're still learning. So if they still need some assistance learning during the next shift or the next day, make sure you report that off to the next nurse and say, hey, we've been practicing on walking with the cane. She still doesn't have the hang of it. So we're going to, I think we should still practice. If they need more practice, make sure you stay with them until they understand fully and they have the strength to be able to use it properly, okay? Always help them back into bed when they're done. When your patient gets in the bed, I know that some of us are clean freaks and we like for things to not be cluttered and things to be all over the place. But if your patient is on crutches or a cane or they have a walker, don't take those away when you leave the room, right? Leave them close to the patient's bedside. So if they need to get up to go to the restroom or something like that, that they have access to it, all right? Leave them at the bedside so that within.
But okay, if their family brings it and they're not supposed to be bearing weight or up walking, is it okay to take it out of their reach?
Yes, it is, because at that point, if the doctor has said no weight bearing, they don't need to be out of bed, period, and the family member says no, they need to get out of bed, I'm gonna leave this walker right here for them, that's going against doctor's orders. So for you, you move it. And every time the family member comes back and puts it there, you move it again. So in that instance, that's a great question. In that instance, you're going to follow your doctor's orders, right? Because if that patient falls and they fall because family brought a walker for them when they're supposed to be bed rest, then that's on you, unfortunately, if they're in the facility. So, I would document. So family has brought in walker for a patient, explain to family that patient is bed rest only, meaning that patient needs to remain in the bed at all times. Explain this to family member. Walker moved away from patient's bedside, and then continue to document like that every time it happens, right? Eventually, something's going to be said to the families to say, stop doing this, otherwise don't come. I mean, I'm sure they're not going to do that, but there's got to be some kind of repercussion to make them understand that their family member can't be up walking around. But anyways, you cover yourself and chart that you have done that and that you have explained it to the patient, you explained it to the family. And that way, if the patient falls because the family has given them a walker, you have already done your part, all right? Once your patient gets back in the bed, make sure that you are taking those vital signs, observing their skin color, make sure they're not pale, diaphoretic, make sure they're comfortable, not in pain, and their energy level, make sure they're not too fatigued, okay? Evaluate their subjective statements regarding the experience, all right? I want you to make sure that you get into the habit of finding out from the patient what the patient is feeling regarding what they're doing. right? So you can observe, oh, patient not fatigued because they don't look like they're tired when they got back in the bed, but she might be because you can't experience that, right? So make sure that you're asking your patient how they're doing. If they have questions, be there to answer them for them. Okay. Right. So we want to make sure that, you know, some unexpected outcomes from our patient in ambulating, they may not want to stay in the bed, right? Because they might be afraid of using something new. They may be afraid of injury, of not being comfortable when they're walking. They might be too tired. So you always want to find out those things when you're dealing with someone who is having to use these sorts of assistive devices, right? And last but not least, you want to make sure that you're documenting what you're finished. You want to note the type of device that the patient had, right? If patient had a walker, then assisted patient with ambulating with walker at this time. Patient had unsteady gait, but remained with patient for the entirety of ambulation. Gait belt was used for patient safety, right? Patient was, let's see, their weight bearing status. They were partial weight bearing to the left leg, and they were able to ambulate without putting weight on that affected leg. Patient required a minimal amount of assistance during ambulation and tolerated ambulating from the bed to the nurse's station without any difficulty. And so that's what you would document in the event that your patient is using one of these, all right? Make sure you, when you hand off a report to the next nurse, let them know how well they tolerated the procedure, or if they didn't tolerate it well at all. You know, we only got to the doorway and then she was so fatigued, we had to turn around and go back to bed, right? So make sure that you pass that off. We were walking and pulse rate went up to 120. So we turned around and went back to bed. So you want to make sure that you're passing off any information that may be pertinent to the next nurse when they're talking about ambulating their patient. Okay. Questions? When performing a safety risk assessment for an elderly patient, which obstacles should the nurse recommend removing from the patient's home?
A.
A.
Everybody says A. I thought for sure somebody would at least say a metal hanger. I'm kidding. All right, so A is the correct answer. If your patient has an assistive device, not an elderly patient, but any patient, make sure they take those rugs up because that's something that they can trip over while they're trying to get around their homes. Okay. All right, guys, we made it to the last section. We're in the home stretch. It's exciting. Now we're going to take care of a patient with an immobilization device. What is an immobilization device?
It keeps their legs like restrained in a way, straight, or like if they have a hip fracture or something, it keeps their legs straight so that their hip can stay aligned.
Very good. So it's, you know, not only just for the hips, but, you know, if you have dislocated your shoulder or if you have a fracture in your arm, you may use a sling. That's also an immobilization.
When they have contractures?
When they have contractures?
Mm-hmm.
I mean, depending on where your contractures of your patients are, because you still want to kind of move them around a little bit if you can. Do you have a lot of patients who have immobilization devices with contractures?
Yep.
More for the feet?
Like their legs, really.
Their legs. To keep them from falling to the side, like outside. So yes, so if we want their body to remain in alignment, so there's some patients who you'll notice to keep their feet from falling forward, we call it foot drop. They may put their feet in little boots to keep them in the correct position. And once again, you still want to do range of motion with these patients, right? Unless it is contraindicated, right? So if a patient's in a pillow like this one, you still want to make sure they're able to move their feet. All right, so it'd probably be a passive range of motion because we don't want to move them too much because the whole point is that they're supposed to stay still, right? We want to make those bones or those joints, we want to give them support and want to keep them from moving, right? So you have different types. You have a splint, which is good to provide support, immobilization, and elevation of the arm or the shoulder. And they usually use these following surgeries or injuries. Okay. Oh, excuse me, that was a sling. I said splint, I'm sorry. That's what the sling is. It will provide that support and immobilization. The splint will immobilize and protect the body part. So let's just say you broke your finger, right? We're really not going to go do surgery on your finger. Those bones are super small, but we can splint it to help it not get any further, more of a fracture, or so we're going to splint it, right? That'll keep that body part immobilized and it'll protect it from any further damage, right? Doctors will order how often or how long that the splint is supposed to stay intact. Right. This right here is an abduction pillow. Have y'all talked about body movements in ANP, like adduction and abduction? No? Very good. All right, so if you're
we haven't talked about it yet.
Okay. So if you're abducting a body part, that means you're taking it away from the body. If you're adducting a body part, that means you're bringing it closer to you. So for this patient right here, this is an abduction pillow, and it keeps those legs kind of apart because you want the hips to be in a certain alignment, like Ms. Jocks was just saying, right? You want to keep your legs apart.
How I remember adduction and abduction. For adduction is AD. So we always would say adduction, abduction. Adduction is to add, like obviously abduction is to subtract, so you move away.
Very good. I think I remember mine by, like, if it's an abduction, if that's what we're doing, you know, when, I guess this is a terrible example, but it helped me remember. So
me too.
When kids get abducted, the kids get abducted, they get taken away. So I remember that is abduction away from the body. It's terrible. I'm sorry. Thank you, Ms. Johnson, for being there with me in that moment. I appreciate it. Okay. So we want to keep our patients who have had hip surgeries. We want to keep them in this position because it helps keep that body aligned and it helps keep those bones where they need to be in order to heal. Right. All right. And here's pictures of the others. So you have a sling here. We all know the neck brace, you know, back in the, I don't know if the people still do it nowadays. I haven't seen anybody do it lately. Don't tell my aunt I'm about to tell y'all, but y'all better not be driving to Florida and run into her because she keeps a neck brace in her car. So just in case, I know, listen, she is out of control.
Where'd she get it from so I can put one in my car?
She's had this thing for years. It probably still, it's terrible. I'm like, why not?
That's a great one. You get stopped by the cops and you're like, I'm sorry.
I can't turn my head. So yeah, so you never know. Be prepared, I guess. Whatever. Probably can get you one on Amazon. It's full of everything nowadays.
Looking right now.
But Duhan is not condoning this.
I'm not.
Just
That's
for the
not what I
record,
said.
not condoning it.
But she told me where to get it from.
But I said you probably could get it from. You never know what's gonna happen. You never know. But what's not gonna happen is you get pulled over by the police and you say Professor Duhan over at CHCP had told me that I could go get one of these neck braces for in the event that I have an accident. I didn't say that.
No, I'm gonna say Professor Duhan helped me put it on.
No.
He showed me the proper way to put it on.
For the record, since this is recorded, I would like to go ahead and absolve myself of this right now.
That's why I said we're gonna go on record. She did not say she condoned it.
You're on the record, ma'am. All right, so you have a soft splint, but this is for Laura for, you know, it's not really a you know, this is more of a sprain, something like that. You're not going to use these. If we actually suspect that you actually have fractures in your neck, then you're going to have one of these guys. And let me tell you, these are not fun patients to have because it's a lot of work. A lot of work. There's all the material in here that you have to clean. And your patient, if they're suspected of having a C-spine fracture, then you have to keep them completely still to make sure that they don't actually fracture it all the way or, you know, become paralyzed. So it can be difficult to work with these patients. In the event that you're taking care of a patient with this neck brace on, then you want to make sure you have a good team around you, right? Your charge nurse should know, hey, we've got this patient, so whenever you're ready to turn her, whenever you're ready to change out the brace, let me know, because it's not a one-man job at all, okay? It's very delicate procedures when you're dealing with fractures of the spine anywhere, okay? And then you have your knee immobilizer, of course. After some surgeries, your patient may have this on, and this is just to keep their knee in the same exact position for healing purposes. When you have a patient that's wearing a brace or a splint or a sling, you can have your nursing assistant do the care. You need to make sure that they know what they're doing, right? They need to review that schedule of wear and what things they can do while they're wearing this brace or the splint, right? Any observations that they may require, we need to make sure that our patients are, not patients, but the nursing assistants, if they're helping out with these patients, make sure they know how to monitor the skin around the splint, around the brace, around the sling, right? Because those things can become uncomfortable. They shouldn't cause pain, but they may. We want to make sure that our nursing assistant can tell us or will tell us if any of those things occur. Okay. Right. If you are going to be applying a brace or a sling, I would imagine if you're just now applying it, that you're probably working in an emergency department somewhere or in urgent care. Most of the time, if a patient comes up to the unit, they've already got their sling on or whatever brace they're going to be wearing. It's already on from the emergency department, unless something happens on your unit. Okay. So make sure that you have whatever's ordered. So review the patient's medical history, their activity level, and why they need that immobilizer or immobilization device, okay? So just make sure that you're monitoring those orders. Ms. Ralph does not have an order for that neck brace, okay? So she don't have one. All right, so just like everything else that we always do, make sure you do hand hygiene. Before you apply a brace or a splint, make sure you inspect the area, the skin, before you put it around there, okay? If there's anything that's, you know, any broken skin, any lesions, you want to make sure you make a note of that, and then you want to make sure that you report that before anything, in case they need to cover it or apply any medication to it, okay? Check the temperature, the pulse, the sensation of the extremity, distal to where the device is to be applied, so away from where the device is to be applied. So if I put a knee splint on, I want to make sure I'm checking the temperature, the pulse, the sensation of the toes of that extremity, the toes and the feet. I want to make sure that that brace is not on too tight, okay? Check your patient's pain level, right? You know, if you need a splint or a brace or something to immobilize an area of your body, it may hurt, okay? So make sure you're determining your patient's pain level so that you can address it appropriately, right? Make sure if the family's around, have them involved, all right? So anytime I've had a kid and I'm having to take care of them and they have that neck brace on, the big one, not the one that we keep in our car. I'm kidding, for the record. Right? The big neck brace, if we have a patient that's got one of those, you want to make sure you involve the family members in the care of, because that's not a temporary, like a day or two kind of deal where they're wearing it. Most likely they're going to go home wearing it, and their family needs to know how to take care of it, right? So make sure that you include the patient and the family in the care of that device, right? Putting it on, taking it off, cleaning any of the cloth areas of it, you want to make sure they know how to do all of those things. Right? So expected outcomes. We want to make sure that wherever we're putting the splint, that skin remains intact. It stays warm. There's no signs of any pressure problems coming, and it has normal sensation. If that is the opposite of what happens with your patient, then that sling or that brace, whatever you're using, it may be on too tight. So you would have to loosen it up. Okay, not too much, but you would have to loosen it up some. Okay, we want to make sure that our patients can understand and apply whichever splint or brace that they have, and they know how to take care of it. Right? Make sure your patient knows that when we're putting the device on, it might hurt a little more than it normally does, right? Because we're manipulating and trying to make sure that we're putting the device on properly. So it could hurt. There may be a temporary increase in pain during the application of the device. So we want to make sure that the patient knows this. Okay. And make sure that, you know, they're using the device correctly and they know their activity limitations. Right? Don't take off the brace so that you could turn your head to go do something, right? How you need to lay down, how you need to move about with using these braces. Make sure that they know all of those things when you put them on. Right? Let's see. All the regulars, if we're gonna put one of these devices on, we wanna make sure we're doing hand hygiene, checking your orders, checking the skin. I like how it says apply clean gloves, but it's optional. Just put on clean gloves. Just, you know, put them on. If it's a back brace, make sure you put a shirt onto the patient before the back brace, okay? Because we want to protect their skin. All right. Make sure that if there's any padding or anything up underneath the brace that you are keeping it from bunching up, because that could alter their skin integrity and you don't want that to happen, okay? Inspect that device. Make sure that it's not damaged before you give it to the patient, okay? If it's damaged, go get another one. If the edges are too rough, then maybe we can take some sheepskin or some moleskin or something and wrap it around the edges so that it'll be more comfortable for the patient. Always check with the provider and make sure it's okay to do that. But typically it is. We usually can do that. Make it a little more comfortable for the patient. But if that device is damaged, don't use it. Go get another one, right? Right, have you guys ever applied a sling before? They're pretty self-explanatory. There's only one place your arm can go in. So it's not hard to do at all. We do have some slings on campus. So if anybody's interested, I'll have them out tomorrow since we're talking about them today so that we can show you guys how to use them, okay? Right, just remember to tell your patient that when they're using these splints or braces, that proper use of them is going to help reduce the pain and it's going to help their healing process. So it's fine if you don't want to wear your knee brace, but your knee's not going to heal and it's probably going to hurt more. So you might as well just wear it, right? When you're caring for your patient with these things, make sure that if they have a splint, it shouldn't be near heat because of what it's made out of. We don't want them to get deformed. We don't want them to melt. So it should stay away from heat. And if by chance they have a leather material, make sure it's treated with a leather preservative. I haven't seen many leather slings or braces for that matter recently. So I don't think you'll need to worry about that at all. But just making sure that they know how to clean their braces properly, because, you know, if it's a knee brace and you're supposed to wear it, you know, 18 hours out of the day, it can get pretty nasty pretty quick. So make sure you're explaining to your patients how to clean them. If anyone's got an immobilization device, and I'm gonna speak on a cast because that's the one that you can't just take off and put on whenever you get ready to. Anybody ever had a cast or had a family member with a cast? I see a few hands. Did they tell you guys how to care for those?
No, but I did do my clinicals at a fracture clinic, and so like I watched them take them on and put them off.
Very good. I hate watching them take them off.
You're not supposed to get them
It
wet.
stinks.
It stinks. It the saw. Ugh. Who said, was that you, Miss Castillo, said you're not supposed to get them wet?
Yeah, you're not supposed to get them wet.
Absolutely.
Don't
If it's a
scratch,
plaster
like,
one.
underneath it or anything like that, because it itches a lot. And they tell you literally don't scratch, but I mean, it's next to impossible because it itches so bad sometimes.
So fun fact, sometimes depending on what kind of cast you have, if you can get a piece of gauze up underneath it, you can kind of wiggle it back and forth. Like if you have a piece of the gauze on the outside of one end and have the gauze end at the other end, if you can do that, then you can kind of sort of, some people will do it anyways when they go to put the cast on, but you don't want to do it roughly, but just enough to where you can kind of, you know, scratch that itch. But you're not supposed to be sticking anything in the cast, like, you know, butter knives and back scratchers and all the things to scratch them. You're not supposed to do that. It's just going to itch. But most importantly, when you have something like a cast on, you want to make sure that you're monitoring and make sure that circulation is still going to the part distal to wherever the cast is. So in this instance, you want to make sure you're checking cap refill of your toes, making sure that patient or that person can feel you touching their toes. There's going to be a little bit of swelling there, especially initially when they first put the cast on. So monitor for that and make sure it's not an excessive amount of swelling. And make sure that, you know, it's all around good sensation. It's not pale, nice and pink is what they should look like, okay? Check for any skin breakdown. Sometimes this area around the cast, depending on which type of cast you have, sometimes it feels a little bit rough and you can put a little bit of moleskin, or not really big enough of a gap to put sheepskin there, but usually you could put a little bit of moleskin around it to kind of keep that from damaging the skin, make it a little more comfortable. Make sure we're checking pain levels in our patient when they have these issues. All right, we want to make sure they're getting medicated. They're not just, you know, writhing in pain and very uncomfortable. Right? Unexpected outcomes related to a patient having an immobilization device. The patient says their pain is worse. All right, that could mean that the device is too tight. I've taken care of people before whose casts were put on and they were too tight. We've had to cut them off. We've had to give them windows in their cast. So just make sure that you're reporting or you're asking your patient if they're having any pain and if their pain has increased worse or has worsened since they've put on the immobilization device. Right? That's all I want to say on that one. And then make sure you record these things, you document, all right? So immobilization device placed to left knee area, left leg. Skin underneath immobilization device is clean, warm, intact. There's no redness, no open areas. Toes and foot to affected foot are, you know, warm, dry, intact, of course. They are, cap refill is less than 2 seconds or 2 to 3 seconds. Sorry, my child is yelling. Please hold just one moment. Let me go tell her to stop it. Okay, sorry about that, guys. All right, so where was I? I was charting. Skin to the foot of affected extremity is warm, dry, intact. There's no, no, that's not right. Skin warm, dry, intact. Cap refill 2 to 3 seconds. Patient has full sensation to foot of affected extremity. What else do I want to say? Patient scheduled to wear this device for 18 hours and verbalized understanding of instructions. Patient is to be non-weight bearing to left extremity and has adhered to this order. while in the care of this nurse. Patient has tolerated ambulation well with device intact. Family and patient understand instructions and had no further questions. So that's how you would document your patient who has an immobilization device. All right, guys, I tell you all these documentation things because once we start in clinicals, you're going to be documenting, okay? We want you to learn how to document because once you graduate, wherever you go to work, they're going to be like, oh my gosh, who taught you guys how to document? You guys are great. So, you know, Miss Jackie and I, we really try to get you guys thinking on the lines of a nurse early on so that once you do finish, then it's like second nature to you. All right. So you hand off to the next nurse. Let's just say your patient's wearing this immobilization device and you noticed a red spot right up underneath their skin, right? So you would be sure to pass that information on as well as let someone else know. Very good. Very good. Right? Oh, where'd I go? All right. So make sure that you are providing patient-centered care. Always assess your patient's physical, emotional comfort. Always keep in mind your patient and their family when you're providing education. Make them involved. Don't just tell them, have them help you do, okay? You know, if you're telling them, oh, make sure that there's no skin breakdown, well, they may not know what skin breakdown is. So explain it to them, show them the patient's skin and say if there's, you know, a reddened area, you want to really monitor that to make sure that it doesn't become a pressure ulcer. So make sure you involve them in their care, okay? Make sure you talk to your patients about their risk for falls because they are at a higher risk of falls if they're unable to use their extremities properly. So make sure you let them know. Make sure that they know that they need to, you know, you wearing these, you're using these crutches, ma'am. You can go out on date night, but please do not put on any stilettos. It's not appropriate, okay? So just make sure that they know all of the ins and outs of what's required and what should be when they are using any of these devices, okay? Make sure the rubber tips are intact and clean and dry when they're using their walkers or their crutches or their canes, right? Make sure if you know, and if you don't know, you can tell you can tell the social worker or ask the physical therapist to give your patient a list of medical suppliers in the area so that if they need a repair or if they need a new walker or a new cane, they know where they can go to go get it, okay? Because this is that patient's mobility and we want to keep them as active and independent as we can. Kids are bad. So your special consideration for kids is make sure they keep whatever device they're supposed to have on, make sure they keep it on, all right? Make sure that you're monitoring, mom and dad are monitoring their babies so that you don't find Legos inside of their cast, okay? Legos, piece of gum, beans, whatever. You want to make sure that, you know, parents are monitoring them because kids are bad and they do what they want to do, right? And they, oh, this is something to put something else in. I'll put a bean in my cast. That's fine. You know, and you got a beanstalk growing out of their cast and that's not okay. So make sure that they're monitoring their kids and making sure they don't put anything into the device and make sure they don't take the device off, okay? Right? For old folks, make sure we're using lightweight devices if we can. You know, grandma's 90 years old. It might not be appropriate for me to give her one of those old heavy-duty wooden canes. Probably not the best of idea, right? Because I don't want her to have a problem holding it up, lifting it up, moving it around, right? So make sure they've got something lightweight to move around, right? Make sure they know how to use what they have, any different terrain that they may be on. Make sure that family members and your patient, your elderly patient know when you sit down, don't move this out of the way, right? So that I can get back up. They want to make sure that they remain as mobile as possible, right? Make sure that they have removed all of the rugs. No electrical cords in the middle of the floor. You know, if you spill something, clean it up. And you know, my favorite is the fanny pack or the backpack on the walker, right? So they can have whatever pieces of whatever they need handy, right? But if they have one of these fanny packs or walkers, just make sure that it's not too heavy because it can tip the walker over. Okay, and then you have a fall. Any questions on our lecture today on mobility? Very good. Before we leave for today, let's go ahead and look at our schedule for Friday. So that we can be sure that we come in at the right time. Okay, we are on week 6. So whatever your schedule says for tomorrow, Thursday, please follow it. No, that part doesn't change. Tomorrow doesn't change. Only Friday will change if you have the CPR class, all right? So let's see. Rockers, you are, let me find your face. I like to look at your faces when I'm talking to you. Are you needing CPR? Where'd you go? Where is she? There you are. You need CPR, Miss Brockers? No? Okay. So you're good for the 9 o'clock class. If you want, you can change to the 11 o'clock class since you do not have to have CPR.
That's what I wanted to do, switch to the 11 o'clock. I have a dental appointment in the morning. I mean, yeah.
I'll switch.
So you talking about Friday or Thursday?
I'm talking about Friday.
Oh, it don't matter Friday. You said just come at 11?
For Friday. So for Thursday, tomorrow, your schedule won't change at all.
Okay.
All right. So whatever your schedule says for tomorrow, Thursday is when you'll come. For Friday, we're changing it up a bit, just a little bit, because there are several who need to take that CPR class. So I can't have them in the 11 o'clock class because that's when CPR is. All right. So if you want to come on Friday for 11 a.m., you can.
Okay.
All right.
Then Ms. Duhan.
Who's called me? Who is it?
Me, Shaylin.
Yes.
So then can I switch to the 9 to 11? Because I'm 11 to 1. Oh, for Friday.
For Friday?
Yeah.
You do not need CPR?
No.
All right. I have you here for the 11 to 1. Where did you want to go to?
The 9 to 11.
Let me see. Let me double check with everybody else that has to take that class because I have to move all of them from 11 to the 9 a.m. or the 2 p.m.
Okay.
So let me see how much space I have. Okay.
I'll go to the 9 a.m. on Friday because I have to take CPR.
Well,
and I'm at 11.
9 a.m. All right. Castillo, are you taking the CPR class?
Yes.
And you're good with 9 a.m.?
Yes, we had already planned that we'd be there all day.
Very good.
Is anybody that's in the morning class, because Friday I already have to be there at 9. Me and Ms. Duhan already discussed that. But for tomorrow, does anybody want to switch that's in the morning class to the 2 o'clock? Anybody? No.
You can go. You can go to 9 o'clock for tomorrow. You're good.
Me?
Yes. Johnson?
Okay.
You want to go to 9 a.m., right? for Thursday?
Yes.
Okay, that's fine. I have space to accommodate. For Thursday. All right. Let's see. Miss Williams, are you needing CPR?
Yes.
All right. So, for Friday, can I move? Which time would you prefer? 2?
What time CPR is?
CPR is from 11 to 1 or 11 to 2.
Didn't I do the 9 o'clock?
9 a.m.?
Yeah.
Okay. And then Miss Talise, are you needing CPR as well?
Yes, ma'am. And we had already discussed about me coming in at 9 on Friday.
Okay. And then everyone else, so whatever time, if you were scheduled for 9 a.m. or scheduled for 2 p.m., you can still come at those times. Miss Mamani, did you want to switch to the 11 a.m. class for Friday?
They lying.
Or did you want to stay in your 2 o'clock?
No, do have 9 to 11?
For Friday?
Yes.
I think I'm gonna have to stay where we're at for Friday morning, since we've moved some to Friday morning already. And all right, I think that worked everybody out. Myers, do you need to, are you needing CPR? Oh, I do not see her. Yeah. All right, was there anyone else that does not need CPR that wants to switch to the 11 o'clock time on Friday? I'm gonna take that as a no. Yes, Miss White, you can come in at 2 for both days. All right. Okay. Well, if all hearts and minds are clear, everybody's good, then I will see you guys tomorrow.
Okay.
All right. You have Miss Jackie's class at whatever time it starts. Be there, be on time. And I will see y'all tomorrow.
Man,
Have a good day, guys.
you too.
Thank you.